Okay, let me start sharing. I think there was some problem. Is it okay now?
So it has just started. Yes, now it has started. Yes, sir. Now it is visible, sir.
Okay, okay. So I'll just go back. Today I'll be talking about achieving glycemic goals, the right approach. If you look at uncontrolled diabetes, we see that diabetes related complications account for most hospitalizations, and these represent almost 55% of the total cost, as was seen in the court's 2 study. And this does not include the small proportion of 7% that is for oral anti-diabetic agents and insulin. This is basically for hospitalization for complications. The UKPDS data has shown that every 1% drop in A1C is associated with a significant reduction in the risk of 21% for any diabetes related endpoint, 21% for deaths related to diabetes, 14% for myocardial infarction, and 37% for microvascular complications. And in fact, if you look at the risk threshold, there is no risk threshold. The lowest risk of complications would be somewhere when the A1C is less than 6%, and we hardly try to maintain that in our routine clinical practice. In India, if you look at the average annual outpatient cost of treating diabetes, I'm talking only of outpatient costs, that is almost around 15,000 per month. And if a patient with diabetes develops a complication, this is going to shoot up to 4 or 5 times this amount per month. So you can imagine the financial burden that our patients are facing. And if you look at across the South Asia, Asia Pacific region, the DEDICOM study showed that in our country, more than 60% of the patients do not attain the A1C of less than 7%, which has been mandated by the ADA or even by the RSSDI. Now, why are we failing to bring people with type 2 diabetes under adequate glycemic control? The basic reason is possibly we intervene too late and we intensify too slowly. So, the key message that I want to give you here is that more than 60% of the patients do not reach recommended glycemic goals despite the availability of so many drugs that we have and the clear cut, flexible, and patient centric guidelines that are available today in 2021. And we need a very right approach to achieve the target goals, because this approach would then reduce the risk of diabetes related complications, improve the patient quality of life, and impact more effectively on the increasing healthcare costs related to diabetes. Now, to achieve this good glycemic control, we need a systematic approach. And this is what I call the 10 commandments. And I'm going to give you these 10 commandments so that you can use them in your routine clinical practice to achieve the right goals for the right patient. Now, if you look at the causes of hyperglycemia, we know the basic two causes have been an impaired insulin secretion from the beta cell and a decreased glucose uptake, so-called insulin resistance in the skeletal, liver, and fat. And then there has been an increased hepatic glucose production, increased lipolysis, decrease in incretin effect, and there is a increased glucose reabsorption, and there is decreased in cerebral defective insulin signaling in the brain, leading to cerebral insulin resistance. And this what the Franzo called the ominous octane. But since then, we have gone much beyond. We know that the catecholamines, including dopamines, are involved. Vitamin D is now involved. The renin-angiotensin system, there is which is also present in the beta cell, and it has a crosstalk with the vitamin D and others, and the testosterone. And we know patients with hypogonadism have higher visceral fat, and patients who are treated for carcinoma of prostate with anti-androgens, they also have a very high insulin resistance and develop glycemic control. Then we know that iron is linked, the higher the serum ferritin, higher the resistance, insulin resistance, and we all know about hemochromatosis, so-called bronze diabetes, This has been called the treacherous 13. Then the gut-derived serotonin, and number of hormones that are linked, and this is called the faithless 14. And then we have the dangerous 3Ds, so-called dust, air pollution has been blamed, organic pollutants, plastic has been blamed, the debris, and of course the noise pollution, what is called disturbance. So these 3Ds have also been blamed, and today we are even talking about this is known as the filthy 15, and today we are even talking about the involvement of gut microbes. So you can see that how much advance has taken place in the knowledge about the pathogenesis of diabetes. And this is just a table which you see find in every book, and you know all the drugs that are available to treat diabetes. But I'm not going to talk about these drugs today. I'm going to give you the 10 commandments, what I was talking about. So my first commandment is know your enemy. That is a very, very important thing. Now, in Godfather, Marlon Brando told his son Al Pacino that keep your friends close, but your enemies closer. So, what is important is an extensive knowledge of the pathophysiological basis of type 2 diabetes. As you have just seen, that how vast it is, combined with a thorough awareness of the efficacy and tolerability of anti-diabetic medication that are available, so that you can best match the medication to patient phenotype. You have to develop the relevant expertise to treat patients with diabetes. And it has been shown in various studies that it is important to get help from specialized doctors who are looking at diabetes patients. And they found that these patients who went for specialist diabetes care had a 17% increase in survival. So the specialist input in care of patients with type 2 diabetes results in greater achievement of glycemic goals and better outcome. Now let's look at three cases. A 28 years software professional, asymptomatic, a fasting of 180, postprandial 260, A1C 8%, he is normotensive, no complications. Case 2, 48 years lawyer, history of weakness and polyuria, is symptomatic, short duration diabetes 3 years, fasting 190, PP 320, blood pressure is high 160 by 90, his creatinine is borderline 1.4, and he has stable angina. And on the other hand, we have a 74 years retired IS officer, his long duration of diabetes of 25 years, a high fasting 160, 240 prandial. He has history of hypoglycemic episodes. His creatinine is very high, 2.5. His A1C is 9%, and he had a CABG 5 years back. Now, what the question is, what should be the glycemic goals, the so-called A1C in these three persons? Because as I said, you have to individualize the glycemic goals. So I would prefer in this young boy 6.5, less than 6.5%, because there are no comorbidities. And this would be fall in the average, that would be around 7%. But in this high risk case with multiple comorbidities, I would be happy to attain an A1C of 7.5 to 8%. So the next commandment is aim for a reasonable glycemic goal. It may be less than 6.5, it may be 7, it may be 7.5 to 8%. So whenever somebody asks you what is the ideal target goal for the treatment of diabetes, your answer should be show me the patient and I'll tell you what the goal is in that particular patient. Now, good clinical judgment to determine the patients who can reasonably and safely achieve these targets without any hypoglycemia. Consideration to individual risk factors is very important. What is the patient's age, prognosis, life expectancy, whether he has complications and comorbidities, and whether he can recognize symptoms of hypoglycemia or he has got unawareness of hypoglycemia. So you have to define the good glycemic control, inform the patient, and make a shared decision, taking him as a member of the team when you're treating diabetes. Now, coming to the next part, it is very important. The ADA has said that monitoring of glycemic status is a cornerstone of diabetes care, and this is to assess the efficacy of therapy and to guide adjustments. So it is important to monitor these patients because you have to keep on adjusting therapy in the treatment of diabetes, and you have this monitoring is going to guide how whether to de-escalate or up titrate the drugs that the patient is getting. And HbA1c is considered the gold standard of long-term glycemic control. It correlates well with a mean plasma glucose. It reflects a mean blood glucose concentration over the previous 2 to 3 months, and it tells you when therapy needs to be changed. So the third commandment is it is very important to monitor this patient every 3 to 6 months in addition to regular glucose self monitoring. So frequent monitoring of glycemia and A1C, it is very important because if the patient has two consecutive measurements which are more than 7%, it means that you have to be a bit aggressive in treatment. And patients who are aware of their A1C value, they and aware of their targets and who are doing SMBG, they are more likely to be self-motivated and achieve the glycemic goals. Now, if you look at the natural history and pathogenesis of type 2 diabetes, remember when the patient comes to us, we think that we are treating patients who are newly diagnosed. But these patients have not been new to diabetes. And on the day you diagnose diabetes, more than 50% of beta cell function has already been lost, and some may even present with complications. Now, it is a diabetes is a continuum of several metabolic processes and is multi-causative in nature. The risk for macrovascular complications begins to increase at lower concentrations in the pre-diabetic range, and microvascular complications correlate directly with glycemia in diabetic range and can be prevented by early aggressive treatment. So the thing is, the message I want to give you is early multi-target intervention. So the next commandment is that we have to address the pathophysiology, the various pathophysiologies, including treatment of insulin resistance, beta cell secretory defects, and incretin defects. And around 80 to 85% of type 2 diabetes are insulin resistance with beta cell defects such as MODY, according for the minority of 10 to 15% cases. Type 2 diabetes has a wide spectrum, varying from severe insulin resistance with little beta cell secretory defects, just like type 1 diabetes, to a mild insulin resistance with severe beta cell secretory defect. Incretin defects should not be overlooked, and don't forget the contributions of increased hepatic glucose output and postprandial hyperglycemia. Now let's look at another case, 50 years female, 5 years diabetes, fasting 180, postprandial 280, A1C 8.5, normotensive, BMI is 22 normal. Now she was put on metformin, bio. Since then, she has been visiting her doctor regularly for the last 1.5 years, who has continued the same treatment regime. Now she comes to you now with a fasting of 140, PP 198, A1C 7.8%. She says that she has also been gradually gaining weight in last 1 year and has gained 5 kg. So why she has not reached her goals? What is the cause? Is it long-standing diabetes or is use of pioglitazone? Is it weight gain? Is it poor compliance or is it treating doctor's fault? Now you can blame any of this here, but I will blame the doctor because he has been seeing the patient regularly and he has not bothered to up titrate the medicine even after A1C of 7.8%. So this is what is known as clinical or therapeutic inertia, defined as the recognition of a problem with the patient's management but failure to act to resolve it. Now, why this occurs? Because there is an assumption of that patient is going to refuse the extra medicines. Or there may be actual resistance by patients. There are patients who will say, I will not take insulin. Failure to set clear targets. You are not aware of what is the target that you want to reach. Or there is poor communication with the patients. So these are important things. And there's a wonderful study known as the Diabetes in Canada Evaluation Study, and it was seen that even though majority of patients were not satisfied with an A1C of more than 7%, yet most of them were conservative in their approach to glycemic targets. So only 68% opted to reinforce lifestyle therapy, 27% augmented the use of oral, and only 8% increased the use of insulin therapy. So that is a very poor flow of affairs as far as clinical inertia is concerned. Now, in the play, the Divine Comedy, Dante said, "The darkest places in hell are reserved for those who maintain their neutrality in times of moral crisis." So, in dangerous times, there is no sin greater than inaction. So, my fifth commandment is that if the patients are not at target A1C, consider combination therapy or step up therapy. Remember, it is better to use multiple drugs than to increase the dose of one drug, because if you increase the dose of one drug, there is what is called as a ceiling effect. So, for example, glimepiride is not going to be effective after 8 milligram, rather, it will cause more side effects. So, the maximum dose is 8 milligram. You cannot go above that. Similarly, metformin, there is no sense in going above 2 to 2.5 grams per day. If you go above that, there will be more side effects, but you will not get the desired benefit. So it is very important that instead of getting increased incidence of adverse effects like hypoglycemia and GI side effects without any benefit of glycemic control, the aim should be early use of combination of submaximal doses of agents that can improve glycemic control without significantly increasing side effects. If you look at the complications rate, we know as the years with diabetes pass, the A1C gradually rises because there is a decrease in beta cell function. So if by the say about 15-20 years later, if you start intensive control therapy, the complications are definitely going to be much higher. But if you start intensive treatment right at the onset or right in the early years of diagnosis, the complication rate will be much less. So, what are the points to remember from this beautiful cartoon? Intensive glycemic control in patients recently diagnosed will greatly reduce microvascular complications. Intensive glycemic control in primary prevention of cardiovascular events is effective, but because of the low event rate, may take many years to document, and even 30 years follow-up has been done in the EDIC and UKPDS study. And as the time passes, the effects of intensive glycemic control on benefit start decreasing. And probably you're not going to see any benefit after a period of 10 years if the patient having diabetes. And this is what we call the glycemic burden. Now, this is the avoidable glycemic burden. And because if you treat early, you can avoid that glycemic burden, which gives a bad name to the cells and leaves with a bad legacy effect. So, if you treat early, be aggressive, you can achieve normoglycemia in the initial couple of years, then you can avoid this glycemic burden. So instead of going this approach with diet, then starting one drug, up titrating, then combination and all that, now we have reached a stage where we are very active, we are more aggressive, so that we start lifestyle, metformin, and maybe another drug together right from day one. Now, so this early combination therapy is basically to preserve beta cell function so that we can reach A1C targets in clinical practice and sustain these targets in our clinical practice. So, sixth commandment, treat patients so as to achieve target A1C levels within 6 months of diagnosis, and that is treating early and effectively with combination therapies. So we are moving from a reactive stepwise treatment to a more proactive approach, because even short periods of hyperglycemia increase the risk of micro and macrovascular complications. And don't forget, along with the drugs, the lifestyle management, it's both exercise and diet, is a very important part of the treatment, and it has to be tailored to the patient's lifestyle. So make timely adjustments to attain target A1C within 3 to 6 months. Now let's look at other case. Three patients with secondary failure to sulfonylureas, fasting 130 pp 260, second case fasting 240 pp 280, and third case fasting 240 and pp 380. Now you have to put this patient on insulin. Which type of insulin you would choose? Obviously, the choice of insulin would depend upon the sugar levels. Here, when the patient's basal, the fasting is high, 240, and PP is not very high, perhaps a basal insulin would be very good. But when the fasting is high, the PP is also very high, you might have to give premixed insulin. So this is the mad world of elections, as you see, the mergers and alliances. So the seventh commandment is use a combination of oral drugs with complementary mechanism of actions and use the right insulin regimen. That is very important. So choosing an agent is an art in treating diabetes. And when you're starting insulin, you must know when to start basal, when to start premix, and how to up titrate and intensify insulin. So best what is suited for the patient's lifestyle, diet, and cultural norms. And it has been shown that if you do it in a proper way, you can reduce the incidence of cardiovascular disease and significantly reduce the cost in managing diabetes. Now, we must individualize treatment in patients with type 2 diabetes. If you look at the significant effects of the drugs, there is weight gain, risk of cardiovascular events, renal metabolism, risk of hypoglycemia. And you have to look at patient factors. What is his BMI, whether he has comorbidities like heart disease or kidney disease, what is his age, and whether he's suffering from metabolic syndrome. So my eighth commandment is be patient centric. That is very important. And consider the patient profile when you select therapy and tailor your treatment to the phenotype of the patient. Look at the baseline A1C, duration of diabetes, what is the life expectancy, whether the patient has complications and comorbidity, what is the risk of hypoglycemia, and very important to the country, what is his financial status, whether he can afford costly drug or not. That is also very important. So there may be times that persistence with sulfonylurea may not be appropriate in long-standing patients with diabetes, where insulin becomes almost imperative to choose and it must be given. In obese individuals, it is very important to ask them to reduce weight by diet and exercise, because that can always control the metabolically the blood sugar much better. And then we have the modern drugs, the SGLT2 inhibitors and GLP-1 receptor agonists, which may be needed in some patients to prevent cardiorenal complications. So the message here is that individuals and not targets should guide diabetes treatment. Now, this is a famous standard 2 trial where it has been shown that compared to the conventional therapy, intensive therapy right from beginning reduced the complications of cardiovascular disease by almost 53%. And what we meant by intensive therapy? A good dietary intervention, regular exercise, stopping smoking, use of RAS blockers, a good glycemic control, control of blood pressure, and control of dyslipidemia. So these are the risk factors. That is very important. So the ninth commandment is, remember, you must control along with hyperglycemia the other risk factors like dyslipidemia, hypertension with the same intensity to obtain the best. Have a holistic approach to disease management. Look at the serum cholesterol levels, the systolic blood pressure, whether the patient is a smoker, what is his, whether it's sedentary, and all that things you have to look. So, a target driven long term intensified intervention aimed at multiple risk factors is very important in the management of diabetes. And remember, the optimal approach to the reduction of cardiovascular risk in diabetes should focus on aggressive management of the standard cardiovascular risk factors rather than on intensive glycemic control only. It is not only that you get the blood sugar down, you have to control the blood pressure, you have to control his lipids, and you have to control his smoking, you have to control alcohol abuse, and you have to get him up and start and walking so that he exercises. Lastly, it is very important what is known as patient education, whether it is be for self-management training or self-management education, and this is basically is a collaborative. And you have to talk to the patient about this disease, so-called diabetes, how to diagnose, how to monitor, self-monitor, what should be the diet, how to what is the behavior modification. So ultimately, it's basically a multidisciplinary team approach. In the endocrine, the patient is at the center, and then there's the doctor, the family doctor, the endocrinologist, the dietitian, the internist, exercise counselors, pharmacists, diabetes educators, podiatrists, ophthalmologists. So it's all a team approach. The last commandment is you have to have a multidisciplinary team approach to the management of diabetes to encourage patient education and self-care so that patient can be involved in the treatment of diabetes himself, because it is very important to improve the lack of understanding of the severity of the disease and the importance of adherence. The drugs will not act if the patient does not, but take those drugs. But if the patient is basically involved, is motivated, he's going to take the drugs, he's going to share with you, and he's going to get a good metabolic control. So it is continuous. This education is a continuous process. It cannot stop with one, just one counseling or one meeting. And you have to involve the patient and the families and have a shared decision making. So basically provide effective communication, education, support, including the use of positive language and by encouraging patient self-management. Give the patient a reason to live in life and say that diabetes can be fought. It's not a very, very serious disease as it is made out to be. So the key take-home messages that I would like to give to you: we Indian Asian diabetics are essentially different from the Western population and require a more aggressive approach. Majority of patients do not reach the glycemic goals, and this is what I call as therapeutic inertia. Knowledge about recent developments in diabetes and newer drugs is very essential if you want to treat them effectively. Set realistic targets and regularly monitor them. Avoid procrastination and delaying, and be proactive, aggressive, and try to get the target levels within 3 to 6 months. There has been a paradigm shift in the treatment. We are now more proactive and aggressive. Use of early combination therapy and timely insulin initiation. Don't delay insulin if the patient requires insulin. Multiple risk factor intervention is very important. It is not only the glycemic goals. A patient centric approach and teamwork with involvement of the patient in his treatment. Remember, it is time for all health professionals to treat diabetes aggressively. It is also time for patients to take their diabetes with utmost seriousness. And it is incumbent upon the healthcare system to provide the necessary resources for both to be successful. Then and only then can we break the barrier of diabetes. Thank you, friends. This is my email address. If anybody has any queries, you can either mail to me or you can ask me even now.
Thank you, sir. Thank you for your wonderful discussion. It was really amazing, sir. So I'd like to request to all the doctors to kindly write the questions in the chat box and Q&A box. So Dr. Manaklal Chordia has raised his hand. I'm unmuting the call, sir.
Yeah.
Dr. Manaklal, hello. Please unmute yourself. Dr. Manaklal, please unmute yourself, sir.
I am Dr. M.L. Chorodia from Bokaro Steel City.
Yes.
Dr. Virmani, I would like to congratulate you.
Thank you.
Thank you so much for your excellent presentation about the compulsory and comprehensive information to all of us. Thank you. Thanks a lot. Thanks.
Thank you. There is a query from Dr. Baldev Prasad, I think.
Yes, sir.
How rational it is to add insulin glargine to regular insulin in twice daily dosing regimen for type 2 diabetes. Okay, see, insulin glargine is a basal insulin to be given once daily. Now, the basal insulin will control only the fasting insulin, fasting blood sugar. It will not control the postprandial blood sugar. So you have to supplement it with drugs which can control the postprandial blood sugar. Either you give oral drugs, which can be combined, and any oral drug, oral anti-diabetic drug can be combined with insulin glargine, which is a basal insulin. But if you have to want to give insulin, then you have to give regular insulin and not pre-mixed insulin. And you can give regular insulin twice a day or thrice a day, depending upon the postprandial peaks during the breakfast, lunch, or dinner. Now, glargine usually is given once a day, but we have seen that about 20 to 30% of the patients may require it twice a day. So it is not truly a long-acting 24 hours drug. The only long-acting 24 hours basal insulin today is degludec, which lasts for almost 48 hours. So glargine has to be given on the same times every day, and 20 to 30% may require twice daily, and you can combine it with regular insulin, but not with premixed insulin. I think anybody else would like to ask any questions?
I'm just requesting again to all the participating doctors that you can just write your questions at the chat box.
And I've given my email. If somebody wants to send me questions on mail or has some queries, I'll be glad to reply back.
So just wait for a minute or two,
Yeah,
sir.
no problem, no problem. Rajni.
Dr. Baldev has said thank you.
Thank you, Dr. Baldev.
So doctors are just giving their feedback right now. So I don't think that there are any more questions from the doctors. So if they come up with any questions, we'll just share with you, sir.
Sure.
So, sir, should we end the session for today, sir?
Sure, no problem.
It was an honor to hear from you, sir. Thank you very much, sir.
Thank you, Ray.
So, good night, sir. Take care, sir. Thank you very much, sir.
Thank you.
To all the participating doctors, thank you for joining the session. We are now ending the session. Thank you very much to all the
Good night,
doctors.
everybody. Please take care.